Title for my presentation today is Recipes for Successful mHealth Implementation and the Need to Look Beyond Technology. The reason why I put this is simply because having worked in this mHealth arena for quite a while, we have seen brilliant technology available, more and more brilliant technology coming, really sophisticated body sensors, etc. But we also have the feeling that, we do a lot of pilots, we do a lot of activities around the world, but there is not really sort of a broad scale or sustainable implementation. So the question is, are there any recipes for success to change that, to bring upon that broad implementation? Or is this just an illusion? Do we have to think in a different way? And for sure, what do we have to do else than just look at the technology? And some of these issues you have been discussing before, yesterday probably, and this morning. Now, before we dive into mHealth, just a few words on HIMSS. I think Cheng mentioned it briefly. HIMSS is probably the world's largest stakeholder organization for health IT. It has been around for quite a while. It's been founded early 60s in the USA, and it's a non-for-profit organization. We have around the world approximately around 50,000 members, individual members, almost 600 corporate members, and over 200 partners, non-profit organizations or other organizations that we work with. The mission is, to put it in a nutshell, to facilitate the implementation of health IT for improving healthcare, or for the betterment of healthcare as it is there, and to provide leadership for people who want to implement such technology. In order to do that, we engage in different activities, and this is just trying to wrap it up for you into how HIMSS in Europe is looking like. We basically talk about three different business units, 3 areas of business we are engaging our activities. We're doing pretty much on the content and event side. We're doing large events like the HIMSS annual event, which takes place in the US and attracts 30 to 35,000 people. We're doing events such as the World of Health IT in Europe, which you might know. Content, we're doing a lot of in terms of providing education, providing expertise, working on certain themes. mHealth is one of them, to provide solid content and expertise in that area. Analytics is another major area for us. Analytics is about creating market intelligence. It's about scoring, assessing the level of health IT in the healthcare system, especially, for example, in hospitals. We are working with a model which is called EMRAM, Electronic Medical Record Adoption Model. I do mention this because we are at the moment doing a huge project with the Ministry of Health in Turkey, where we want to assess over 800 hospitals in your country for their IT equipment or for their stage of IT. It's a model which works in stages, and the result of that screening, which takes place over the next 2 to 3 years, is really to give the Ministry of Health a clear idea of how the situation health IT-wise looks in the hospitals and what can be done to improve it, i.e. give the Ministry of Health a clear idea of where they should spend their money and where they should, budgeting for. Finally, media. We're having our own media channels to communicate whatever we do, whatever we work on. And we also do, of course, media publications for partners or clients. So that is in a nutshell what HIMSS is about. If you haven't mentioned it, Cheng, HIMSS is for Health Information and Management System Society, which is pretty long, so this is why we always call it HIMSS. But let's dive into mHealth. Whenever you look into market reports, whenever you look into analyst reports on mHealth, you always find phenomenal growth rates, and that mHealth is always the area, almost in the whole of ICT, which almost finishes always on top when it comes to growth potential. And these are just figures I picked from Roland Berger for a while ago, and it sort of gives you an indication, or what Roland Berger thinks should be an indication of how the whole E and mHealth sector will grow in Europe. You can really take any report. The figures differ a little bit, but the basic is always the same. Base is always the same. A huge growth potential. If we look at deployments, mHealth deployments worldwide, and this is data from GSMA from 2012, GSMA looked at what are the mHealth initiatives, the mHealth projects that are currently being deployed, are currently being run throughout the world. And you might think quite a bit and quite a number of, if you look on them. However, 90% of those initiatives which you see there are pilot trials, and this is part of the problem. We do a huge number of pilot trials, but we're having difficulties to really then turn it into a sustainable implementation. And there's this saying, infamous almost, you might have heard it, that there are probably more mHealth pilots in the UK's National Health Service than there are pilots in British Airways, which quite dramatically shows a little bit the magnitude of the whole thing. So why is this so? Why do we have pilots, but not in many cases, not so much broad-scale implementation? One of the reasons is for sure that we have to look beyond technology, as I mentioned it in the beginning. We have brilliant technology available, yet in many cases, people are reluctant to use technology, as I try to picture it in this slide. Technology is there, people don't use it. Why is that, and how can we possibly change that as we go along? One of the reasons, or possibly the most important reason, the most severe reason, when it comes to why it is so difficult for a large-scale implementation of mHealth is simply the fact that in most countries, the healthcare system is actually still working in silos. The healthcare system traditionally has always been working in silos, so you have like the hospital silo, you have the physician silo, then you have the emergency or the outpatient care, as I put it here. And traditionally, there's not much interaction been going on between those silos. Now, here along comes mHealth, and mHealth is really unfolding its power only if you work across the silos, because otherwise it only makes limited sense. So you have to look towards the notion of integrated care, if you want it or not, but that's what you have to do, otherwise it will have only limited effect. Now the fact that we work in these silos in many countries implies a couple of things. There are no, as I mentioned in the beginning, no or little processes or workflows in between those silos. There is no really experience or no foundation for work or interchange between the silos. So that is one problem. The other is the absence of legal frameworks or regulatory frameworks. For example, the whole area of liability. Whenever you work across the whole care continuum, you in many countries find there's a vacuum of legislation, so people are afraid of being sued, being made liable if they transfer data from one entity to the other. A huge problem in many countries. We don't have so much criteria for validating outcomes when it comes to mHealth and really benchmarks, because whenever we do health economic studies, most of the time it's within a silo, but not across the whole continuum. So that's another issue which we have to tackle. And last but not least, there is a growing incentive for payers and providers and patients to use mHealth, but in many countries, this is still a critical issue, that there is no real political willingness, no driver really, no incentive, no entity who really incentivizes people, patients or professionals to use mHealth. So what do we have to do to change that? The situation is as it is. It is evolving and it is moving, but how can we make sure that we continue to be on a successful path? And I think, and this comes back to is that we have to look beyond technology, is really what else do we have to address? Business cases for sure. We have to look into how we put technology into organization. We have to look at technology itself, what technology makes sense for which kind of patient or which kind of users, and policy and regulatory. And I will go a little bit into each of these, not into depth because we don't have the time, but give you an impression of what it could look like if we tackle all these areas. And let's start with the business cases. In order to understand a business case and develop a business case, you have to understand the different players in the healthcare system and the benefits you can bring along with an mHealth application. There's a lot of things you can do with mHealth. You can go, for example, to the hospital arena and can say, look, dear hospital, you can, if you supply patients with a remote monitoring system, you can do an early discharge, so you save money. You can go to the public or private healthcare system, say, we're gonna take care of your chronic population, less costs, better quality of life. Same you can do with your elderly population, or you can go to the pharmaceutical industry saying if you use mHealth technology or mHealth applications, you might have a handle on improving your patient compliance, which can be a sort of you might have a chance, if you do clinical trials, to collect data in a faster and in a better way, data data with more quality. So you have better outcomes data from your clinical research, or you can go to the pharmaceutical industry and say, this with medical applications and services, you can have a handle on controlling medication safety and security in a much better way because you have the immediate feedback, you have the immediate connection to a patient. So this is something you have to understand. It is different from country to country, even different from region to region. So you really would have to sit down and say, what are the stakeholders and what are the value propositions I can offer to them. For example, I would, if I go to a hospital and say, look, I give you a remote monitoring system and you can discharge people on average 3 days earlier on, you can save money. If you have a hospital system where the hospitals don't have a chance to reap the benefits, i.e., where they don't get compensation from the health insurers, for example, or they cannot keep the benefits, or they cannot keep the costs they save, they have no motivation. And hence, it doesn't make sense to put an mHealth solution into a hospital for early discharge. So these are the kinds of things you have to be very carefully examining, and you have to very carefully analyze that. If you do not know your stakeholders, if you do not know how they work, if you do not know how they can really reap the benefits, you are not able to position your mHealth solution and application or services in a good way. So understanding that is of key importance. Just to give an example on how we calculated the business model for German hospitals a while ago, we sat down with some hospital CIOs and medical directors and said, supposedly we have a remote monitoring system where you can measure quite a number of body parameters. How many patients would you be able to discharge earlier? In total, they said an estimation of 20 people going through hospitals in Germany would be eligible to early discharge. We have around 17 million going to hospitals in Germany each year, which makes 3.5 million. So 3.5 million is your basic population that you might be able to discharge earlier on. Hospital lane in Germany costs on average 420 euros. Doctors saying we can on average save 3 days, and you do the calculations straightforward. The 4.4 billion at the end of the equation are basically your savings potential for the hospitals in Germany in that case for early discharge. Now you have to be fair and say, the savings are great, but there are other people who also want to do business, and the business model has to work across the whole value chain. And you would also have to look at the costs. And this is what we did. We worked with one particular telemedicine system, remote patient monitoring system, which had a lifetime of 3 years. So we calculated all the costs across the lifetime of 3 years. And of course, you have to pay for the solution itself, which you see there, but you have to pay for the other entities in that service chain as well. So you would have to provide for the hosting provider, for the service provider. These are the guys who run the service for you on a technical point of view. You have to pay for the medical service provider. In that case, that was a call center. So any medical question would, you have to have a person, or you have to have a group of people who are able to answer that question. And you have to pay the network providers. For the data traffic, you go forwards and backwards. And if you all add it up, it's still less than the total savings you see on the left-hand side, which the hospital could reap on using such a system. So in that case, very clear-cut business for the hospital. Still, taking into account all the costs, they would still make a profit, and they would still make a substantial savings of 25,000 euros in that particular case. So this is a business model which would work if the hospital has the right actually to keep these benefits. If a patient is discharged early and it just costs less and the hospital sees nothing of whatever the hospital saves, the hospital has no motivation and it doesn't work. So this is something which works in a setting where the hospital has the liberty to actually, do that business and sort of manage the business also from a financial point of view. The second area which I mentioned was organizational change and organizational development. We have to bear in mind that this is not only, and this is perhaps to a lesser extent even about technology, we're talking about people. And we had this very good presentation this morning where we talked a lot about change management. Healthcare was always one of the areas which was very reluctant to adopt new technology. The reason is because people were fearing that they were losing their assets, they're fearing that they were losing their business, they were fearing that they could be charged for malpractice. So this transparency which is created with mHealth, because everybody has access to the data, creates a lot of fear and insecurity. And we have to make sure that we accompany people throughout this process, through a clever change management process. And there was much talked about this morning, which was pretty much the way you should handle that. Just to give you an indication of how important that is, we were talking to Kaiser Permanente a while ago, to the CEO of Kaiser Permanente, one of the biggest health plans in the US. They spend, I think, $4 billion on eHealth and mHealth, and 2/3 of this $4 billion they spend on change management. So they realized the magnitude of the problem, of the challenge, and I think that's a very important piece of the puzzle. Talk to the people, make sure that your organization is adopting that, and make sure that you capture the people as you go along. Processes are very important, so you have to get your processes right. It's not just about putting a piece of technology on somebody's table and say, now you run with it, you measure and you collect data. The question is, what do you do with the data? How do you follow up the patient? And this is an example I was working on a while ago in the Middle East. It was about remote patient monitoring for cardiology patients. And you can see, without going into detail, that what we tried is to include all the stakeholders into that monitoring process. So we had the patients in the hospital who were collecting the patients. We had the mobile operator in there who was providing a secure network, the solution provider with the monitoring systems, of course, the support centers, and the payers and the insurers. So having that whole ecosystem in there allowed us to put up a pilot project, which is good. But having all the stakeholders in there also made us sure that if the whole thing works and if we could show meaningful results, that we have a reasonable chance of implementing, after the pilot ends, the whole thing into daily care. So this is the way you have to go. You have to think about how to include into that whole delivery chain and how you design the processes. Technology, I don't want to go into much detail into that. Don't go into detail. A take-home message there is if we're talking today about a good technology platform for medical health, or for mobile health, then it consists of two parts. What you see on the right side is the sort of the device management part, which takes care of really configuring your devices, managing your devices, handling everything around mobile devices. And the left side is pretty much about the communication part, about the C in the ICT equation. And that is really a full-scale communication platform that allows you to get into contact with the patient, not only measuring values, but communicating with the patient. If you have such a platform, you can basically, if you do it in an agnostic way, put a lot of applications on there. So that's today the state of the art, how people are looking at building that technology layer, which enables then different applications and solutions to be put on that. Finally, regulation policy. Different situations in different countries. We try to map for some countries in Europe where they are in terms of market potential and market regulation. On the right side, of course, those guys who have heavy market regulation. On the upper side, those guys who have a huge market potential. Cluster 1 is about the big countries in Europe, like France, Germany, Italy, Spain. Huge markets, heavy regulations, so not easy to tangle. Then you have like UK, which is kind of a huge market, but with less regulation, I postulate, because the NHS is there. And if the NHS wants to do something, they do it, and you have to face less regulations. 3, we're talking about Northern Europe, mostly Northern European countries. Netherlands is there, Belgium is there, so Those countries who have sort of a medium market potential, but especially Scandinavia, which are very well on their way when it comes to the implementation of mHealth. So less regulation there, smaller markets, but less regulation there for those guys who want to go into a market in Europe and have a sort of potentially a very quick return on investment. You would go to these markets and then sort of, take it to the other markets. Especially Scandinavia is very much in front as far as Europe is concerned for the implementation of mHealth applications and services. The cluster number 4 down there is a little bit the question mark, where we have somewhat smaller market potential and somehow unclear regulation or unclear bureaucracy situations. Regulatory is basically, there are a number of regulations existing. The most important are coming from the US and the European Union. It's FDA, it's HIPAA, it's the Medical Device Directive, or it's the CE mark. And wherever you go in the world, most countries are actually looking to either one of those. So the implications rather of what I just showed you is, if you ask yourself, how to build a launch strategy or a go-to-market strategy for mHealth applications, you usually start, probably if you are wise, with the application or the service which gives you the least of disruption if you go across the silos. So something like this, and this is not complete for sure, but just some ideas how we see it. So on the lower left-hand side, you will see those applications which are less prone to disrupt the whole thing, and which are quick to adopt. So like appointment reminders, compliance management with simple appointment reminders, for example, medication reminders. This is the stuff that is usually easy to implement and rapidly to adopt. And if you go up then across the scale, the most difficult thing is probably full-scale disease management, where if you really want to do good disease management with mHealth, we have to work all across these entities. We have to work all across the ecosystem, and that is a challenge which takes time. So it is doable. We have seen that in countries, but it takes time, and you have to go stepwise. In summary, what we have seen is it's very important to understand the value chain, who is there, who enjoys the benefits, who hosts the funds, who pays for the whole show at the end of the day, and who drives the implementation. If you don't have a driver in the market, very difficult to do something. So drivers can be the social security, the healthcare system, the healthcare insurers, the government, the industry. It doesn't really matter. As long as you have one who is driving it, you're on the safe side. Otherwise, it's going to get difficult. Business model we talked about. It's important to have a business model which goes all across the chain and not just for one single entity. If you have one entity in the service chain which is not able to produce benefits, material or immaterial, the whole thing won't work. So, business model or benefit model is very important. End-to-end solutions and offerings, very important as far as we are concerned, to look at not only a piece of technology which you just give out, but to look at all what it does to implement that technology into your organization. So from change management, from people motivation, people education, really to processes and process management. Last but not least, validation data to prove the case and to state the case. All of that, and that brings me back to my first slide really, is if you look at it, of course, different from country to country. So your value chain and your player looks different if you go from one country to the other in the world and in Europe, for sure. And your ways, the structures inside a healthcare system are different. So the way you have to position and to implement your mHealth solution may vary from country to country, even from region to region. So, and I think we have a nice example. David's 3G doctor business case is a very good one, which works very well in the UK. But we had the discussion before lunch. It might not work in Turkey. So this is the kind of things you have to be watchful for. So when it comes to the question, do we have a recipe, a general recipe? Probably not. Not a recipe that you can just take and sort of take it from, Turkey to Germany to France to England. That does not work. What we have is sort of like a cookbook where you have different ingredients in it. And if you understand the ingredients, you are very well capable at the end of the day of remixing these ingredients into different recipes, which are then applicable to the different areas you want to go. So we believe if you go down that way, then you're on the winning avenue. But it's been one of the biggest frustrations over the last years that people thought we take an mHealth solution and this is a one-fits-all thing, which I do in one country and just can replicate in another. We would have to treat these things on a pretty much individual scale. And that was basically it. I just wanted to one thing which I wanted to draw your attention to is HIMSS is gonna, I said, on top of our international events, we're doing local and national events, and there's going to be one in Turkey in May next year. So this is something you might want to keep in mind, 12th rather to 13th of May in Istanbul. And having said that, I am through with my presentation and curious to hear your questions. Thank you.
Thank you so much for the presentation. I'm Dr. Brukedalı from GSK. You showed an excellent mapping of market potential versus market regulatory status. Where would you put Turkey now that you're in the collaboration with Ministry of Health?
It's a very good question. I actually wanted to throw back that question at you. I'm not sure. I mean, I see Turkey developing a lot of things at the moment. So for sure, it has a great market potential. So it would be in the area of the big markets in Europe by its sheer size, for sure. I think when it comes to mHealth, you still would have a way to go, but that doesn't really matter if you're actually willing to do so. Then, I think you have a very good chance to become a driver in the whole game. The question is, for example, I don't see these things happening in my own country, Germany, or in other big countries because there is so much political reluctance to drive, the implementation. And I see, seeing all the dynamics which are going on in Turkey. As HIMSS, we're doing a lot of things in Turkey at the moment with the ministry, and now you're doing this thing here. So I think if you continue this, I think you're probably going to be on the less regulated, high potential side sooner or later.
So a question from me. So it was written that you have saved, or you would save 4.2 billion because you get rid of the readmissions, right? To the hospitals per year.
You discharge them, earlier on, like they stay for, 10 days and you discharge them after 7, something like that.
No, the early discharge is something else. So, as I remember, just getting rid of the readmissions to decrease is 4.2, and we didn't see the total of the early discharge. Do you know how much it is? What about?
The total of the early discharge was, I think it was 4.4 actually. That is just if you send people home, in that case, 3 days earlier. What we did not do in that study was calculate the savings through avoiding people coming back after, 10 days, 2 weeks. That is something which is not included in that number, which is important. We didn't look at it, but that's another thing I suggest you do. If you look, for example, to this, the biggest trial in mHealth has probably been taking place in the UK. It's called the Whole System Demonstrator. They did like 6,000 patients over 2.5 years, chronic patients, diabetes, I think it was COPD, and it was cardiology. And they exactly look at that parameter. They looked at readmission, they looked at mortality rates, and they could show that they significantly could lower the rate of readmission. So You're right, it is an important thing, and I would examine it. If I do a project, I would make that part of the metrics.
Okay, great. Okay, thank you, Rainer.
Thank you.